for the wonderful introduction. And good evening to participants. I'm really excited to be part of this workshop for several reasons. One, like Dr. Bazagan mentioned, I'm the Director of Infection Control and at MLK, Martin Luther King Outpatient. And I also share the Infection Control Committee. And we've been working very hard to make sure that, we get through this COVID-19. Without taking much of your time, Edward, can you put the first slide?
Is it better?
No, you have to zoom it. How do they see it? Do they?
Hold on 1 second.
We can see it, but you probably just need to put it in slideshow.
Yeah.
Yeah, there you go. Hold on.
There you go. Okay.
There you go.
Okay.
Sorry about that.
So this is the second time I'm giving this talk. A lot has happened since the first time, so I've modified it to accommodate those changes. We're all now familiar with the COVID-19. Every day CNN and all the news outlets talk about COVID-19, that all of us now should be experts. But it's very important that we go back to how it started and when it started. Sometime in December, some patients were diagnosed with pneumonia in Wuhan city, but they first reported it to the World Health Organization on January 9, 2020. And then the genetic sequence of that virus was then made available within weeks after its discovery. And it was found to be beta coronavirus, the same as the SARS coronavirus and the MERS coronavirus that we had in the past. Next slide. This slide will give you a kind of timeline of the major global events of the COVID-19 pandemic. And if you follow from December 2019, you would see that early December, that was when it was first, the first cases were first identified in Wuhan. And then if you fast forward to March 2020, you will see that that was when the World Health Organization declared the COVID-19 as a pandemic and made their announcement. And from then on, most countries started noticing cases, and we here in the United States had our own share of cases with surges that we noticed between August and October and July. So this is just to give us a kind of background information on how we got to where we are now. Next slide, please. This data was obtained about 3 days ago, and it tells you how many cases we've had in the United States. And as of March 17, which would give you the data from March 16, we had 29, a little over 29 million cases in US, with a little over 500,000 deaths. Next slide. Next slide, please. This gives you an idea of what we have in Los Angeles. We had like 1.21 million cases and 22,520, a little above 22,000 deaths. And that's in Los Angeles County alone. Next slide. So, what is coronavirus? We all know the structure of coronavirus. We all know that there are these spikes around like a king's crown. That's why it's called corona, the shape of a corona. And these spikes give it its shape. It has multiple proteins. It's a single-stranded RNA, enveloped single-stranded RNA, and it has about 4 key proteins. And these proteins are very important in its virulence. The S protein, which enables it to attach and enter the host cells. And then you have the M protein, which is the membrane protein. We have the nucleoside protein, which helps with replication, the RNA replication. And of course, we have the envelope protein, which of course is the least understood, but we know that it probably has a role in viral assembly and release. Next slide. This gives you an idea of the structure of the virus and how the vaccines that we have are derived and where they target. As you can see, the spike protein S, that is the protein that most of the viruses that we have now in circulation target. So we have the viral vector vaccine, which is the AstraZeneca and the Janssen vaccine. And then, of course, we have the RNA-based vaccine, which is what the Pfizer and the Moderna viruses were, the vaccines were. Next slide, please. This slide gives you a brief idea of the stages of infection and immune response to the coronavirus. We do know that the virus binds to the ACE2 receptors on the epithelial cells using its S protein. And that's the stage 1 of the infection. And then by the stage 2, when it gains entry into the cells, then it presents its viral antigens to both the CD4 and the CD8 T cells. Then we have the programmed cell death, which is called apoptosis of the infected cells. And then we get to the stage 3, when the inflammatory cells are released with pretty much what we'll call cytokine storm. Next slide, please. This pictorial slide of what I just told you. You could see the stage 1, the epithelium, and then by the stage 2, it has gained entry into the cell, and by stage 3, you have the cytokine storm. Next slide, please. Well, the COVID-19 symptoms, of course, are very common symptoms, which we notice in most upper respiratory tract infections, including the flu. Most patients would present with mild symptoms, and some may not even have symptoms. The symptoms usually are fever, chills, myalgia or muscle pain, some sore throat, some may have vomiting. However, we get concerned with those who have very severe symptoms. At that point, they have severe illness with respiratory failure and would require respiratory support. Most of them get admitted to ICU, and if not treated or if they don't recover, many of them succumb to the disease and die. Next slide, please. Who is at risk to contacting the COVID virus? Usually people who are at risk for most infectious diseases like the flu. We're talking about the geriatric population, the people who are 65 years and above, people who also have chronic medical conditions such as lung disease, cardiac disease, advanced cardiac disease. We also know that people who are obese, and we're talking about BMI of more than 40 or equal to or more than 40, do also are susceptible to this disease condition. Infection with human immunodeficiency virus and other immune depressed patients. Next slide, please. There was a study that was done because there was concern as to whether mental illness is a risk factor for COVID. And it was found that individuals with psychiatric diagnosis were about 65% more likely to be diagnosed with COVID-19. Older COVID-19 patients also had a 2 to 3-fold increased risk for first dementia diagnosis. So there is a bidirectional relationship, therefore, between mental illness and COVID. Next slide. So we all know, at least now, that COVID predominantly infects the airways. And like I said earlier, the symptoms will range from mild respiratory infections to severe acute respiratory syndrome. The most common COVID-19 symptoms are kind of symptoms you would see in people who have the flu. Next slide, please. So, the medical management of COVID-19. A lot of research work has gone into ways of managing this condition. And we do know that prevention is always the best course. So the prevention strategies that are being used at this time include, but not limited to, the public health guidance of masking, having a distancing one from areas, large crowds, areas that people may probably get exposed to people who have the condition. But then vaccination is still the key, because we would want to stop those viruses from entering the cells and by getting people vaccinated. When they get symptomatic, we do have treatments for those. Next slide, please. So like I said, the best way to prevent the infection is to avoid being exposed. Next slide. CDC also recommends what I just stated. We're all too familiar now with these strategies. Next slide, please. So the question is, vaccine or no vaccine? I like this slide because, quite frankly, if we can share it with anybody who has doubts about the need to get vaccinated, we could share this slide with them. Without the vaccine, you're taking a chance that the virus will get to your cell with the spike protein, gain entry to your cell, get to stage 2, and then get to stage 3, when you have the cytokine storm, and then with that, there will be increased inflammation and disease progression, and the person may end up in ICU. With the vaccine, we see from the bottom that there is no entry. The virus cannot gain entry to the cell, therefore there won't be infection. Technically speaking, of course, we could get some infection if we get vaccinated, but technically speaking, if you have the vaccine, then the chances of the virus entering your cell with the spike protein and permeating the epithelium will be kind of reduced. Next slide, please. These are the prevention strategies and therapeutic options. I'm not going to go into detail, but there are drugs, the antiviral drugs, and we have the anti-inflammatory agents. Now we have the monoclonal antibody, we have plasma therapy. So over time, we've developed a lot of drugs to combat this disease when they present in a very severe form. Next slide, please. So this slide kind of elucidates what I just mentioned. We have the convalescent plasma, the antiviral and chemotherapeutic agents. We're also using monoclonal antibodies. Next slide. So, like I stated earlier, the SARS-CoV-2 binds to the ACE2 and the TMPRS2, SS2, that's a serine protein, and gains entry into the cell, and then results in all the things I mentioned. These two receptors are very important because we do know that COVID is less common in children than in adults, and there have been a lot of research work in this area. And one of the findings is that children do not express the ACE2 and the TMPRSS2 receptors like adults. So that may be the reason why they are probably not so much at risk. But that's beyond the scope of this lecture. Can we go to the next slide, please? So now that brings us to vaccines. Next slide. This slide shows the 3 vaccines that we do have EUA in the United States. You have the Moderna, you have Pfizer, and then you have Johnson & Johnson. Next slide, please. As of 2-3 days ago, about 111 million doses have been given in the whole of the United States. Of these, about 39 million people were fully vaccinated. And then you could see from this slide the percentage of population fully vaccinated, 11.89%. So we still have a long way to go. In California, the percentage is not that different, and 13.2 million doses have been given so far. So when we say fully vaccinated, we're talking about people who have received the 2 doses, or people who have received 1 single dose for the single dose vaccines. Next slide, please. So this is the same thing that I mentioned. The worldwide, it's even more disturbing. About 1.13% of the world population have been fully vaccinated. Next slide. The same thing I mentioned. Next slide, please. So the vaccine types for SARS-CoV-2, like I stated earlier, looking at the structure of the virus and the proteins, you would see that most of the vaccines that were created were targeting those proteins or the whole virus. We have inactivated vaccine that uses the native virus, which has been rendered deficient from heat or chemical treatment, so they are not virulent anymore. We also have the live attenuated vaccine that can replicate, but in a limited manner that cannot cause the disease. We have the subunit vaccine that incorporates subsections of the native virus, such as the S protein. And this is the one that Pfizer and Moderna fall under. Then we have the viral vector vaccine. The viral vector vaccine, they use viruses, but not the COVID. They use the adenovirus, and then they use that as a vehicle to get the RNA eventually to pretty much precipitate immune response within this, just the same way that Pfizer and Moderna are. Then we have the DNA vaccine, and then we have the RNA encapsulated within the liponanoprotein to decrease RNA degradation. This is more or less expressing what I just said. You see the viral vector, the attenuated virus. You have the DNA vaccines, you have the subunit viral protein, and then you have the inactivated virus. Next slide, please. This is comparing how some of the vaccines work. As you can see, the AstraZeneca is a viral vector, and then it requires 2 doses, and the storage is 2 to 8 degrees centigrade. Then you have the Moderna, then you have the storage is very important when you consider the on the developing parts of the world where you may not have reliable power supply. So the Moderna is stored at -25 to -15, and the Pfizer is -80 to -60. Janssen is a one-dose viral vaccine, and it's 2 to 8 degrees centigrade for storage. This is the modified RNA vaccine. The way it's packaged, lipid nanoparticles, and the vaccine, when it gets into the arm, then it gets the host cell to make viral proteins, which will now induce immune response. So this is a very simplified schematic presentation of how the vaccine works. Next slide, please. We're all aware of the historical impact of vaccine. We all know that vaccines over the past 100 years have been used to combat very infectious diseases. We do know that treatment of infectious diseases also is very expensive and very costly, and impacts on the day-to-day life of people all over the world. So widespread preventative vaccination can lower these costs, and also plays a pivotal role in reducing transmission. There is something we call the herd immunity, which is people who get immunized go out in the population, and other people get some immunity from that. So the more people that are immunized, the more chances of getting a very good and high herd immunity. Next slide, please. Vaccine development all over the globe for COVID-19 pandemic has beat all records. We had the Operation Warp Speed that was introduced that fast-tracked vaccine development in the United States, and it has helped us get a lot of vaccines available for distribution and also to get people get the shots they need. Next slide, please. I know that many of us have had questions about why they should trust a vaccine that was developed this fast. It's one of the reasons why some people say they will wait for some time before they allow or before they can accept the vaccine when offered. One important thing we need to know is that COVID-19 is not the first SARS. So we had the COVID SARS, we had the MERS, and research had been going on this. So the science was ready, and studies were large, and there was coordination between countries and companies, and that also helped facilitate the early development and of these vaccines, and EUAs were then offered by CDC. Next slide, please. So this slide gives you a kind of idea, just so that you know that when people are concerned about the speed of the development of the vaccines, it's not without merit. On the left side, you will see the traditional vaccine production usually takes 10 to 15 years. You have the preclinical studies that will take about 18 to 30 months. Then you have the phase 1, when safety evaluation is done, that takes about 30 months. Then you have the phase 2, when safety and efficacy evaluation and immunogenicity is done. That takes like 32 months. And the phase 4, which is to do with manufacturing and distribution, takes like 12 to 24 months. On the right, you see what happened with the COVID vaccine. It took 2 months for the preclinical studies because there were data from the pre-existing SARS and COVID, SARS-CoV and MERS-CoV, and also the phases 1, 2, 3 were lumped together, and that took like 6 months with overlapping trials, and the phase 4 took 4 months, which is emergency use authorization. So that's the difference. So 12 to 16 months as against 10 to 15 years. That's why people are a little concerned. This explanation should be what you would have, ready to dispel those doubts. Next slide, please. So this kind of explains a little bit more what I just showed you. That slide. Next slide, please. So, COVID-19 vaccines approved through emergency use authorization. A lot of vaccines, next slide. A lot of vaccines have been authorized. You have the Moderna, Kaiser, you have the Pfizer, BioNTech, and then you have the Janssen. So these are the vaccines that have been pretty much authorized. How effective are COVID vaccines? You can see from this slide, you see the Pfizer is 95% effective, the Moderna 94%, and the other vaccines listed there with their effectiveness. The Johnson & Johnson is 66%. Next slide, please. This is comparing Moderna, Pfizer to flu vaccines, okay? So when you hear about this effectiveness and we're throwing out numbers, it's good to put it in perspective, okay? The Pfizer is 95% and the Moderna 90%, and this is the storage temperature. And then you see the flu vaccine. There is a difference. The flu vaccine is an inactivated virus, okay? And it requires annual injection. The MMR vaccine is 97% effective against measles, rubella, and 88% against mumps. Look at the flu vaccine. The flu vaccine is 40 to 60% effective, and yet it helps us stop the spread of flu during the flu season. Next slide, please. This is the Johnson & Johnson. Next slide, please. I want to throw out some definitions so that, when you're saying these things, you will understand what they mean. Like, vaccine effectiveness is described as the protection that is provided by immunization in a defined population. It includes both direct, which is the vaccine-induced, and indirect, which is the population-related protection, herd immunity, okay? The effectiveness of a vaccine is also proportional to the efficacy, but also by the vaccine coverage and other factors, including access to health centers, okay, socioeconomic factors in that community. And we do know that from research, more than 70% is desired to eradicate an infection. So what that means is that, like, we have the coronavirus now as a pandemic, the vaccines should be at least 70% or above efficacious for the infection to be eradicated. Okay? A preventative vaccine with an efficacy of less than 70 will still have a major effect, and they end up decreasing the length of the infection. So if a vaccine is less than 70, it doesn't really mean that that vaccine is not effective. Next slide, please. Now, This is another important word, the vaccine hesitancy. This is defined as a delay in acceptance or denial of vaccination, regardless of the accessibility of the vaccination services. Remember the other slide I said, people may want to get the vaccine, but because of other factors, access to healthcare, access to the vaccines, they may not get it. Now, the hesitancy is for those who have access to the vaccine, but regardless of that accessibility, they still decline the vaccine. It's complicated, it's affected by factors such as complacency, convenience, and confidence, okay? And it's important in the effectiveness of the vaccine, the vaccine uptake in the population. Next slide, please. This is a slide I like. I'm sure many of us have heard the word the anti-vaxxers. The anti-vaxxers always pose a threat, okay? They are the ones that come up with misleading beliefs, myths, and they will search the whole web to find reasons not to take the vaccine, and they will not end there. They will try and convince their families and friends not to take those vaccines, and I've heard it all. Next slide, please.
Sorry, Dr. Uyanne, you have 2 minutes more.
Okay, oh, thank you, I have to. Okay, okay, go to the next slide. Go to the next slide. Go to the next slide. Now, let me talk about the variants. Let me talk about the variants of the COVID. So, like I said, there was genomic sequencing. The viruses, constantly keep changing. It's not surprising that we now have some variants. Next slide. This slide shows you the US COVID-19 cases caused by the variant. We have the B117, number of cases reported in the United States, 4,686, with 50 jurisdiction reporting. We have the B1351, and then we have the P1. The B117 UK variant, South Africa variant, and the Brazil variant. Next slide. Thankfully, in California, we only have 375 cases of the B117. We have 4 of the B351 and 1 of the P1. Next slide. This just shows you the distribution. Next slide. Next slide. Next slide. Next slide. Now, let's talk about the myth and confusion about safety and efficacy, because this is where I need us to have the information to dispel the myths, okay? COVID-19 misinformation is just like I stated earlier, it's like normal information that you get, but inaccurate. Go to the next slide, please. So, misinformation, of course, I stated earlier, false or inaccurate, not supported by scientific evidence. Next slide. This is me getting the vaccine. Next slide. These are some of the myths. Is it safe for me to get a COVID-19 vaccine if I would like to have a baby one day? And the answer is yes. If you're trying to become pregnant, yes. Next slide. COVID vaccine and fertility, no impact on fertility. Pregnant women likely to transfer antibodies to unborn child. So it could be a good thing. Next slide. COVID vaccines were developed using fetal tissue. Current vaccines do not use fetal cell cultures. It's different from fetal cell line. Next slide. Next slide. These are still some of the myths. There are myths like, do I need to wear a mask after I'm vaccinated? Yes. Some people say, oh, can the vaccine give me HIV? The answer is no. Does the vaccine change my DNA? The answer is no. It doesn't get to your notice. Next slide. So these are fetal cell lines. The Vatican Congregation for Doctrine of the Faith released a note on COVID-19 vaccines in December. And this is very important. When ethically irreproachable COVID-19 vaccines are not available, it's morally acceptable to receive COVID-19 vaccines that have used cell lines from aborted fetuses in their research and production process. Very important. There's a difference between fetal cell line and the fetal culture, cell culture. Let's go to the next slide. Oh, we made it.
Yeah.